Okay, so the next talk I'm going to give you is on endovascular procedures. I thought, I'd start with two YouTube presentations. I'm sure most of you know endovascular procedures, for at least on the neurosurgery end, are procedures that we do by putting catheters up from the groin, threading them up into the neck, and then up into the blood vessels of the brain, and then doing various things, coiling aneurysms, treating AVMs. I'll go into the gamut of things that we do, but I'll start so you get a flavor with a video for the coiling of a, can we put lights down if we can? For treating of an aneurysm.
Lights down. Yep, hands on the way.
Endovascular coiling. And unruptured unfounded.
Can you hear that?
February 2012.
Where do we have it? Oh, you know why?
I moved the mic.
No, I didn't turn it off. Oh, hello? Yeah. You moved the mic. Let's see.
The surgeon and narrator are Dr. Michael Horowitz. Here we see the aneurysm. This is a phallic segment aneurysm. Here we have a roadmap view. A wire and catheter are being
This
advanced
is central.
from the groin into the head. The wire will be placed into the aneurysm, and the catheter will be placed over the wire into the aneurysm. Endovascular coiling. An unruptured ophthalmic artery
Is that
aneurysm.
coming now?
February 2012. The surgeon and narrator are Dr. Michael Horowitz. Here we see the aneurysm. This is an ophthalmic segment aneurysm. We have a roadmap view. A wire and catheter are being advanced from the groin into the head. The wire will be placed into the aneurysm.
This is the internal carotid artery. The eye wire would be here. This is right behind the eye. Here's the eye. You can't see it, obviously. There's a catheter tip.
We see the catheter in the aneurysm, and the wire is
It's
removed.
about a 4 millimeter, 4 millimeter aneurysm. That shouldn't be
Now
there,
advance
obviously.
the first coil into the aneurysm. This is an approximate 5 millimeter diameter aneurysm. The platinum coil is going to be advanced, and it will take several manipulations to get it to fall into the right position. Because of the angle that this aneurysm arises from the vessel, the catheter has a tendency to move in and out of the aneurysm as we coil it. Here we see the coil entering the aneurysm. Here the coil is radiating out of the aneurysm to the neck, and we therefore withdraw it and start to re-advance again so that it will assume a better shape. At this point, the entire coil is within the aneurysm. We're ready to release it. We're now advancing a second coil into the aneurysm. This coil is smaller diameter than the first coil, so that it fits within the first coil, much like Russian dolls fit together. This is actually called a Russian doll technique. Here, the coil wants to herniate out of the aneurysm and push the catheter back. We will simply manipulate the coil of the catheter to get the coil to ultimately stay within the aneurysm. It often takes several attempts to manipulate the coil and catheter until we have satisfactory positioning of both devices. gently so as not to rupture the aneurysm. Here the second coil is within the aneurysm, is being repositioned slightly, and it will now be released. A third coil is advanced into the aneurysm. It too wants to herniate out of the aneurysm, and therefore it is withdrawn. And it will be remanipulated in advance until we have it in acceptable position. You're satisfied with the coil's position, and we will release it. Here's the final result. The aneurysm no longer opacifies. It is completely filled with coils. Here is the coil mass behind the right eye. Again, another run showing the aneurysm completely obliterated. Another run, once again, showing the coil mass. The injection is in normal blood vessels. The aneurysm no longer fills. This was the aneurysm before, and this was the aneurysm after treatment. Here is the aneurysm after treatment. The dark mass is the coil mass sitting above the blood vessel in the aneurysm.
Okay, so that's coiling of an aneurysm. It's one type of procedure that I think will be hopefully do fairly frequently here once we're up and running. And these patients typically will go to the intensive care unit overnight. So, we used to put them in a step-down unit, but here they'll go to an intensive care unit overnight, and then they will they go home the next day and back to work the day after that. That's for an unruptured aneurysm. We probably are not going to do many ruptured aneurysms here. They just stay in the hospital too long, and we'll send those down to West Penn. Here's just for another type of case, and then we'll go on some slide presentations. This is treatment of an ABM, which is a tangle of blood vessels in the brain.
ABM embolization using Onyx 18. February 2012. The surgeon and narrator, Dr. Michael Horowitz. Here we see a base catheter in the left internal carotid artery. An arteriographic run is done, showing a tangle of blood vessels in the left frontal lobe. This is the artery.
Got a buffer for a second.
Your venous malformation.
So we want to get rid of that.
This will be removed surgically after embolization is carried out. Here, a small microcatheter is advanced through the blood vessels. It will be sequentially placed into each of the blood vessels that is supplying the arteriovenous malformation.
You can see how much further we're going to go out into the vessels now.
Here, the catheter is being advanced over a small micro wire into one of the anterior cerebral artery branches
cerebral artery
that
and
is
the
feeding
anterior
the
cerebral artery.
arteriovenous malformation.
We're going to go out, way up the anterior cerebral artery.
At the bottom of the screen, the tip of the catheter can be seen being advanced over the wire.
Here's the catheter. There's the wire that we're steering up there through the different turns.
This is a road-mapped view that allows the surgeon to steer the wire and catheter around the various bends in the blood vessels to reach the arteriovenous malformation.
So we want to get out.
The dense cluster of vessels in the center of your screen 12 and 1 o'clock, or 12 and 2 o'clock, is the arteriovenous malformation. It is fed primarily by the anterior cerebral artery and its many branches, and partially by the left middle cerebral artery and its branches. Once the catheter is in position, we will do an arteriographic run through the catheter to see if any normal brain is opacifying along with the AVM. We then will inject a medication, lidocaine or amytal, to see whether or not there are any neurologic deficits in the patient. If there are no neurologic deficits, we will continue with the embolization
So this is
by
done.
injecting Onyx 18 into the feeding vessels and the AVM.
So this case, the patient's asleep,
Here's a
so
view
we're
of the
monitoring their
catheter's
brainwave
advance quite
activity,
distally.
and we're seeing the changes when we
The
inject the
AVM only is
lidocaine.
opacifying.
Here's the tip of the catheter way up now. Before we were down.
Once again, the
Here.
AVM is opacifying.
This is part of the AVM is filling. We're just in a branch, one of the branches to it.
We've determined that our catheter position is good for this portion of the embolization. We will now go ahead and begin to inject the Onyx 18, which is the black material that is appearing on the screen.
And this is basically a liquid. When it
This is
comes
a
out, it
liquid
turns like paste.
that, when it contacts blood, goes from a liquid to a solid state. It is dark because it is mixed with tantalum, which appears under x-rays. Here, a portion of the AVM is being infiltrated with the Onyx 18, and these vessels will permanently be sealed off. This will make the surgical resection easier, as there will be less blood flowing to the arteriovenous malformation at the time of surgical resection. Once we are satisfied with the embolization of this feeding vessel to the AVM, we will remove the catheter. The catheter has been removed, and a fresh catheter is now being advanced over a wire into another vessel that feeds the arteriovenous malformation. We will advance it into another branch of the anterior cerebral artery that gives blood supply to the arteriovenous malformation. That branch also will be tested with lidocaine and amytal, and if the patient does not show a neurologic deficit, we'll move on to embolize that branch and the supply to the AVM from it using the Onyx 18. Here the catheter is being advanced over a wire, and it is passed distally through the artery towards the AVM. Once again, the wire is distal to the blood vessels supplying the AVM, and the catheter, whose tip you see, is being advanced over the wire into the vessels supplying the AVM, trying to get as close to the AVM as possible. An arteriographic run is done showing filling of the AVM, and the patient again will be tested with lidocaine and amytal. Embolization now will be carried out with Onyx 18.
See, even though the catheter is way back here because the onyx is
the onyx
traveled
exiting the catheter
deeper
and
into
filling
the
the
AVM.
arteriovenous malformation. Once again, the dark material is the onyx. The injection is done slowly in an attempt to try to get the onyx to travel out distal into the AVM to seal as many blood vessels as possible to make the surgery easier and safer. As we inject more onyx, you can see the outline of the AVM as it fills with the material.
Trying to make the blood-filled part of the AVM smaller and smaller, so that at surgery, even though we take everything out, this is all dead. It's just like taking out a glob of glue that's in a hose, and it makes the surgery a lot faster and safer, a lot less blood loss.
Some of the areas within the AVM that are rounder in appearance are most likely small aneurysms within the nidus of the arteriovenous malformation. These are often the sources of bleeding when an AVM hemorrhages. Here we're sealing off the vessel that is feeding this portion of the AVM. We'll soon pull the catheter more proximally to embolize some additional vessels that we had identified. The catheter is now being slowly pulled more proximally. It will be gently re-advanced, and additional onyx is injected, which will enter another portion of the AVM. See, this injection shows that the portion of the AVM that was embolized no longer fills with blood, while areas that were not embolized do fill with blood.
All this late
Here we see
stuff
the AVM
fades,
is
that's fine. I'm trying to
reducing
fill the
in
arterial
size
portion, which is here. It's not filling anymore.
and volume. The catheter is being advanced into another vessel. This was the AVM prior to embolization. In total, we embolized 6 individual vessels that were supplying this AVM. The image this is the AVM prior to embolization. The area within the circle. Once again, a lateral view showed the AVM prior to embolization. The dense angle of blood vessels represents the arteriovenous malformation. The circle shows much of the AVM prior to embolization. This is the AVM after embolization. The volume has been significantly reduced. This is an anterior-posterior view, and the circle shows the residual arteriovenous malformation that will not be embolized. The arrows point to the onyx material within portions of the AVM and feeding vessels. We have embolized both anterior cerebral supply and middle cerebral supply to the lesion. Here's a lateral view of the AVM after embolization. Primary supply now comes from one middle cerebral artery branch. The dark material with the arrows represents the onyx.
Okay, so those are just two sample procedures that are done with embolization. Go back to the talk now for you 1 second. Okay, so what time do we have till? 1? Okay, for this talk. Okay, so show the YouTube videos. So what are some procedures that we do aside from what I just showed you? Well, balloon test occlusions. This is one where you want to know whether or not somebody needs an artery in their head or whether they can do just as well without it. Usually it's done before we do certain procedures to remove tumors that might encase the artery. And we want to know if we have to spare that artery or we can just get rid of it at the time we do the tumor. So we'll inflate a balloon temporarily while the person's awake. The balloon is attached to a catheter in the artery, block the blood flow there, examine the patient, and while the balloon's inflated, if their exam remains the same, take them over and get a CAT scan and do what's called a CT perfusion study. We're actually looking at the blood flow to the brain while the balloon's inflated, and we will see whether or not how that looks compared to when we do deflate the balloon and do it. And if it looks very, very similar, then we and the person passed clinically, meaning that when the balloon was up, they didn't show a deficit. We know that there's a very low likelihood that if we sacrifice that vessel, they'll have a subsequent stroke. Now, if they look normal if they would behave normally when we inflate the balloon, but we take them over and there's a lot of asymmetry on the blood flow studies with the balloon inflated versus uninflated, then even though they tolerated it clinically, we know that that person's at risk for having a delayed stroke. So you could take the artery, they could do fine, but let's say they went home and dropped their blood pressure a little bit, or the operating room dropped their blood pressure a little bit, those people might be susceptible to having a stroke. In that case, we know that in some way we need to preserve that blood vessel. Other procedures you might do is actually sacrifice a vessel with an embolization. We showed examples of that with the AVM. We might sacrifice the vessels more proximally. We talked about tumor. We talked about AVM embolization. I just showed you that. We can do the same thing for tumors before we take them out. Tumors that are very vascular, we can go and get rid of the blood supply to the tumor, making it faster and easier to take that tumor out. We can do that whether it's in the spinal cord, the bones of the spine, or the brain. Aneurysm embolization, I just showed you. Sometimes we'll use other devices like stents or balloons to help us coil that aneurysm, but essentially the procedure is as I showed you, except there are additional steps if we're using other devices along with it. Angioplasty of the carotid artery. Instead of doing carotid endarterectomy, we can go up with balloons and stents and open up arteries and take them from a narrow area to a normal area to increase blood flow to the brain and reduce the risk of stroke. And we can also do that on blood vessels that are in the brain, if those are narrowed as well, with balloons and stents. Sclerotherapy, we've all seen people come walking around with vascular abnormalities of their face or lip. You look at them, they're blue mottle bulbous areas, and they can have them elsewhere in their body. Those procedures can be treated by just putting needles in percutaneously while they're awake and injecting alcohol to sclerose the vessels and damage the lining of the vessel so that it seals itself up and collapses. WADA testing. WADA testing is when most often used for people that have epilepsy or people who are having a part of their, or you're anticipating removing part of their brain for one reason or another, and you want to know what that portion of that brain is responsible for, so you put a catheter up into that part of the brain, give the person a barbiturate, amytal through that catheter, and put that part of the brain to sleep temporarily and see what kind of deficits they have. It's speech, movement, typically you're going to be testing speech, both speaking and comprehending speech, and memory. Petrosal sinus sampling, probably not something we're going to be doing here. People that have certain types of tumors of the pituitary, Cushing's, where they have too much cortisol being produced, we would go up and We want to know whether that's being produced because their pituitary tumor is causing it or whether it's being produced from elsewhere. We therefore go up and we want to test the blood that's coming out of the pituitary gland in order to determine whether this gland is hyperactive or not. And so we go up with catheters and we draw blood samples over periods of time with without stimulation of the gland to see whether or not that is where the tumor is, on what side of the gland, and if there is in fact a tumor at all. Thrombolysis, that's for stroke treatment, and that's for removing clots from the blood vessels of the brain, either by suctioning them out, grabbing them with some devices and pulling them out, or going up with lytic agents like tissue plasminogen activator, going up to the clot and infusing that into the clot, and then tubal blood flow augmentation with certain devices with patients with spasm. So there are other things we do. Epistaxis, people with nosebleeds very commonly will come and have bleeding from the posterior aspect of their nasopharynx. We will go up and seal those vessels off just very similarly to the way we did the AVM to stop their nosebleeds. You'd think that would be uncommon. It's actually a fairly common procedure, especially in older people. And then there's trauma, things that we don't really see here, gunshot wounds where people are actively bleeding, or penetrating wounds to the head where they have aneurysms that form dramatically that we need to treat. I'm just going to show you, run through a bunch of cases here just to give you an idea. This is a CT of the head. Eyeballs would be right below here, but here and here, there's the midline of the nose, midline of the head. These are the sinuses, the maxillary sinuses. Here's a tumor right here. See, it's not one on the other side. This is called a juvenile nasopharyngeal angiofibroma. It's a tumor that's typically found in children. It's a child that'll tell their parents and their doctor, my nose is always stuffed, I have trouble breathing. Very often they'll have blood, they'll have nosebleeds. It's a benign tumor, but it can cause problems, and we typically will embolize that before it's taken out by the ENT surgeons, and it's taken out by going up through the nose. But if you don't embolize it, you can lose a tremendous amount of blood during surgery. And so here's the tumor. This is looking at the head from the side. This is looking at the head straight from the front. And here's one eyeball. Here'd be the other eyeball. The nose is here. And here's that tumor blush right here. You can see how vascular it is. Here's the blood vessel running into it. The maxillary artery, internal maxillary artery. This is all tumor. And you can see if you took a bite out of this with an instrument, it's just going to diffusely, blood's going to pour out. Actually, I made a mistake there. Here's the blood supply coming up here. This is a vein that's actually draining it. Sorry. Here again, J&A tumor. This is looking at it from the side. This is the internal maxillary artery here. You see all this is tumor. Here's the tumor before. You can see that there, and there. And here afterwards, you don't see it because we injected particles into it to block off the blood supply to it. Also makes it, sometimes if you wait a while, it makes the tumor easy to take out because the tumor doesn't have any blood supply anymore, necrosis. The tumor gets softer, more liquidy, and you can take it out more easily just by suctioning on it. Pre-embolization tumor. Post-embolization, not there anymore. In terms of blood supply, it's still there, but there's no blood going to it. Here's a meningioma of the brain. Right here, this is the middle meningeal artery coming up, and this is the meningioma blushing. And this tumor is being embolized to decrease the blood flow to it before it's taken out. Here it is here. Here you don't see it anymore. Again, the tumor is still there, but the blood supply that you're seeing here has been cut off. These procedures are all done at weight that I've shown you so far. This is a tumor in the neck. It's called a globus tumor. It grows. Here's the internal carotid artery in the neck branching into the common carotid artery in the neck branching into the internal carotid artery and the external carotid artery. And these tumors grow in the crotch between these two vessels. You can see the tumor right here, this area here. You can see here's the tumor blushing here, and here you don't see any blushing at all. And we've embolized the blood supply to this, and now it's going to make it a lot easier to take out, a lot easier to preserve these vessels, because you can now see what you're doing without having a lot of bleeding. Again, here's that tumor from the side. See how it's, I told you it grew from the crotch. Normally the internal carotid artery and the external carotid artery, here's the common, they branch. Normally they're right next to each other. But you can see the tumor grew from here, from cells that are located at the crotch of these two vessels, and see how it's pushed the two vessels aside. And here it is before, here it is after. Again, very little blush there. It's still pushed aside because the mass is there, but the blood supply is less. And now this tumor can be dissected off of the vessels here, off the vessel here, and just take it out as one piece. Another tumor. Okay, epistaxis. Here's somebody, this is their eyeball here on the right side, in their skull. Here's a blushing to their nose, and they're bleeding from this. So they're not actively bleeding. It's very rare that you see active bleeding, but this is hypervascular mucosa, and that's what's causing their bleeding. So we go with a catheter here, and we just seal all these vessels off. Okay, you can see over here, this used to be here, now it's not, and their bleeding stops. AVM I showed you before. I showed you angiographic images. This is what an AVM would look like on an MRI scan in the brain. Here's an occipital lobe AVM, looking at the person from the side. This is their occipital lobe. Their ear would be right here. AVM here. So here's the lateral view before and afterwards. No AVM. AVM is still there, but there's no blood supply to it. The blood vessels have been filled up with material, and now you can take this thing out just like it's a tumor without worrying about getting a lot of bleeding and making the operation more difficult. Another type of AVM right here. This is the middle cerebral artery. AVM here. Now you don't see it anymore. And this is a lateral view of the same AVM, looking at it from the side. AVM here. And you don't see it anymore. I showed you this. I showed you about the onyx. I just showed you a case of onyx embolization on the YouTube video. But this would be an example. There was a big AVM here. Now it's been embolized, and this is all an onyx cast of the AVM. And then you can go ahead and take that out, take out this cast. There's very little AVM still that's still filling and alive to take out, but it makes it a whole lot easier to take out all this embolized AVM and does the part that's filling versus this whole thing right here that's filled with blood. It's kind of like diffusing a bomb ahead of time. Gunshot wound to the head. You can see that this is a normal side, okay? Maxillary sinuses, sphenoid sinus right here. Nose on this side, the midline. Here's the left side. And compared to this, you can see this is all shattered. This person had a gunshot to the face, and there's going to be bleeding out through here. There's a large artery, the internal maxillary artery flows through here. That's going to have been lacerated by the impact of the bullet, the bony shards, and the bullet itself, and the pressure wave from the bullet. You can see this person is, unlike I told you before that the people with epistaxis, nosebleeds, you don't actually normally see active bleeding. When you study them, they're just constantly oozing, and then it stops and it starts again. This person is actively bleeding. We inject dye in the internal maxillary artery, and this is contrast that if we kept filming, showed you an active film, this would continue to leak out through here. There's an actual hole in the artery, and they're bleeding out, sanguinating through their nose and face. So went up here, and you can see here's the artery that has the basically end of it cut open, and now you don't see this artery anymore. It ends right here, and we filled it quickly with metal coils to seal that off so no blood supply goes up there anymore. Here's a vertebral artery in the neck that, through a car accident, has been damaged. It's been dissected. And what a dissected artery is, you have to think of arteries as having like a steel belted tire, multiple layers of a wall. As long as that wall can get ripped up for one reason or other, whether it's spontaneous for some reason or traumatically from twisting the neck, or twisting the neck hard in an accident, this goes through bone, and when it gets twisted, it gets traumatized as it goes through a bony canal, and it can get damaged. And when it's narrowed now because the inside is all ripped up, and blood clots can form here because the blood flow is very turbulent. And you can see that this dark area of the brain here versus here, this is the cerebellum. This is the area we were operating on before when I told you when I showed you that surgical procedure. We were actually operating right down here in the brain, where here's the cerebellum, and here this black cerebellum. This is dead tissue, and it's had a stroke. It's had a stroke because of this. So we want to go up, but we don't want to have more strokes happen to other parts of the brain that are fed by this artery. So if you have another one on the other side, most people don't need both. So instead of keeping this open and as a source of emboli, we'll get rid of it by going up here with a catheter, putting some coils in here, and permanently occluding this vessel. And here you can see it filling, and here you can see it's coming up filling, and then it stops after we embolized it. I told you you have one on the other side. So we've sacrificed it on this side. Here's the stuff we put in. Okay? Inject the other vertebral artery. It comes up, goes up here, fills the basilar artery, and then some of it comes down and fills the part of the vertebral artery that was distal to this damaged segment. So its blood's coming up here, going down here, filling this artery here, but it's not going up and filling around down beyond here because we've sacrificed this segment. And they still get plenty of blood to their brain because they can come up here and go up this basilar artery from this route instead of this route. And the blood can come up here, go around here, and out this artery here, which is important. There really are not a whole lot of important artery branches between here and where it comes off the aorta. So you can get rid of the whole thing as long as you have one on the other side. Here's a person came in with a stroke. You can see the internal carotid artery comes up here, winds up here. This is where I showed you that aneurysm was before, coming up the internal carotid artery on the YouTube video. Here we come up, and then this is the middle cerebral artery. It should fill out like this, come up and continue out like this. Here you can see before we treat the patient, it's not filling at all, just blood just stops right here, blood with contrast in it. So this person can't move the left side of their body. This is the right side of the brain here. So we've gone up with a little small catheter. We've gone past this occlusion with the catheter. We inject dye. We see, well, the blood vessels are open out here. It's just that there's a focal clot right here that's stopping blood from getting to here to here. So we pull back. In this case, we put urokinase in. We dissolve this clot here. We inject dye from below again, and now you can see everything's reopened. And now we'll be able to fill blood from here to this part of the brain. Another case of urokinase on the left side. We don't use urokinase anymore, but we use other drugs, TPA, which is very similar. You can see the vessel comes up, fills the anterior cerebral artery. The middle cerebral artery stops right there. There's no filling of the whole middle cerebral. This person's left side, so this person would come in unable to move the right side of their body, especially their arm. They also would not be able to make any speech, and they wouldn't understand anything you were saying to them. And you can see afterwards, this area wasn't filling over here. Now it is filling. And over here, this area wasn't filling, and now it is filling after you dissolve the clot. Again, another embolus right here. Comes up normally, then look, nothing's filling here. A little bit of blood's getting past it, but it's just trickling past this occlusion right here. See how it gets really narrow? And now you can see, oh, I'm sorry, this is the left side of the brain. That was the right side of the brain. We inject the left side, you see, oh, blood comes up, goes up here, and does provide blood connected from the left side to the right side here, but it's not going out the middle cerebral artery, but it is going at the anterior cerebral. So we know we have to get this vessel open so we can fill the middle cerebral artery on the other side. The clot here, so this vessel should continue on. And afterwards it does continue on, after that clot's been dissolved. Of course, that's not always, you haven't always done the person a favor by doing that. This person didn't have blood supply here, they were paralyzed beforehand. Sometimes, though, after you either that tissue's already dead before you get to treat it, or it's not dead, but the person just can't tolerate losing the blood supply and having blood supply given back to it because the brain's too fragile now from being ischemic for a while, and later on they bled into the area of the stroke. So it's not always, just because you get the vessel open doesn't always mean that you're going to have a great outcome. This is a device, I told you before, sometimes we can do things called to increase the blood flow to the brain. This can be done for stroke in people in one of the treatments, and people for vasospasm. And this is actually, even though it's the brain that's having the problem, we're going to do something in the aorta. We're going to go up, and the renal arteries come off. Here's the aorta, is here. Okay, you don't see it, but it is here. And the renal arteries, here's, you can see the this is the contrast in the renal calyces draining out into the ureters. Kidneys are here and here. The renal arteries are right here between these two balloons. What somebody found was if you inflate a balloon above and below here, for some reason it either changes the kidney's production of renin and angiotensin. Nobody's sure exactly what, but it will increase blood pressure and increase cerebral blood flow to the brain, even after you deflate the balloons. That effect remains. So sometimes this is a treatment that we'll do to increase blood flow to the brain in somebody that has cerebral vasospasm. Here's an abnormal connection between the veins and the arteries behind the eye. It's called the carotid cavernous fistula. Here the carotid artery comes up, and you can see it going up and blood going into the brain. But in this area, the carotid artery comes up and it goes through the cavernous sinus. Cavernous sinus is a collection of veins. Then sometimes, they're separated from the blood. The blood in the artery is separated from the blood in the veins. But sometimes that artery can get a hole in it for one reason or another, either traumatic or spontaneous. So now you have blood coming up, and now instead of the blood just staying in the artery, it leaks out into the veins, into the venous area. So it puts those veins under a very high pressure. Now the veins that normally see very low pressure, because they're just draining blood out of your body, are suddenly seeing arterial pressure. So you have arterial blood going into the veins. So now blood used to flow, here's the eyeball over here. So blood used to flow out of the eye in this direction, okay? And then out into the jugular vein, down to your heart. That's how the eye drains. In this case, there's now a hole. So now not only can't blood drain out of the eye, but blood's going in the opposite direction in the veins. Instead of coming this way, it's now going this way. So now the eye can't get rid of blood, and it's also getting too much blood. And all of a sudden, these people will come in, and their eye will be coming out of their head. So what you want to do, and that can happen elsewhere also, but in this case, what you want to do is you want to seal that hole off so that the blood can't go out of the artery into the vein. So you want to put a catheter up, go across the hole, go into these veins, and seal these veins off. If you do that, the arterial blood can't go into these veins to the eye. The eye can still use other routes of venous drainage, even after you get rid of these veins. And you can see we've gone across the hole, and we put these coils in those veins. So now blood comes up the carotid artery, and it can't go out towards the eye. And now the eye will drain normally through other routes, and the eye gradually becomes normal. And you can see we've done that. The blood keeps going up the carotid artery into the brain, but it's no longer filling the veins of the eye. Here's somebody, another gunshot to the head. You can see these are fragments, metal fragments that are in the head. And when these fragments went into the head, they lacerated the blood vessels of the head to create aneurysms. They weakened the blood vessels. These are called traumatic aneurysms. These can bleed, and they have a high incidence of bleeding frequently. So anytime there's penetrating trauma to the head, a knife, a nail, bullets, things like that, you want to do an arteriogram and make sure that that the blood vessels aren't damaged, you don't have traumatic aneurysms. If you do, you need to get rid of them. So here we see one right here. We've gone up with a catheter, put it right here, inject contrast. The catheter's right here now. We inject it. We see the aneurysm filling here. And here we're going to seal it off by putting up some coils and seal this vessel off so that it doesn't fill anymore. Here it's going to have certain veins that drain the head that become occluded, and the blood can't drain out of the head anymore normally. Be for a variety of reasons. In women, it's common because of oral contraceptives, which make you hypercoagulable. Also, women that are postpartum, they have very high blood volumes, and they can be dehydrated. When I was in Texas, we would see a lot in the summer because it was so hot, and people would get dehydrated. And so you would go up with a catheter in the venous system, and you would leave the catheter in for a while, and you would infuse overnight clotting thrombolytic medications like urokinase or TPA to dissolve the clot so that it opens back up again. And you can see here, it's where it wasn't filling, and now it is filling the next day. Showed you aneurysms before. Here's an aneurysm before, aneurysm afterwards after it's coiled. This is the catheters that we put up in the head. These are the coils that I showed you we were putting into the head. This would be one coil. It's like a slinky made out of platinum. When I told you we'll now release the coil, we can either mechanically in some companies or electrically apply a current, and the coil, which is attached to a wire that goes through the catheter that we pushed it up with, separates right here. You can pull that wire out, the coil stays in, and then we can push another one up. And this is kind of what I showed you on that YouTube image. This is what we were doing. Big giant aneurysm here, coiled. Not really anything import here. Aneurysms, these are just aneurysm cases. New developments, putting stents up in the head in order to help coil an aneurysm. I don't have any good pictures there. This is another type of AVM where we go up, we inject material. Here's the abnormal connection between arteries and veins. You can see we put a catheter right in here. You can see just the abnormal areas filling, and now it's not filling at all because we blocked that off. I told you about balloon test occlusions before, about putting a balloon up and temporarily occluding a blood vessel to see whether you need it. Here's the balloon inflated in the artery. This is just dye injected distally to show that we've occluded. It's not washing out. We inject the dye just sits there because there's no blood coming up from below to wash it out. And that's, again, I told you the reasons before to see whether somebody needs an artery or not. Vasospasm after subarachnoid hemorrhage, you can see this is how a vessel should look. This width, see how narrow it is from the irritation of the blood products around these blood vessels. So we go up, we put a balloon just like they do in the heart, put it up into these vessels and dilate it up so it goes from this to this, and we can increase the blood flow to the brain. Same thing here. See how narrow this vessel is, the middle cerebral artery, compared to this. We've put a balloon up and dilated it. Stenosis here. Stenosis here in the basilar artery. We'll go up and dilate it up. Here's another stenosis, another stenosis. Here we've gone up with a balloon and a stent in that artery where it was narrowed. You can see we went from this, just like they do in the heart, to this with a stent and turned it into a normal vessel, so there's normal blood flow to the brain. More gunshots with bleeding. Some of this stuff is carotid stenting. Here's a internal carotid artery. This would normally get a carotid endarterectomy. You're going to open this narrowing up. Instead, we go with a catheter and a stent. You kind of see this area here. That's kind of modeled. That's the stent you see there. It's been opened up with a balloon, and you can see the vessel went from this to normal without having to open the neck. Here, again, another one, normal. Some of these are repeats, that's why I'm getting rid of them. That's it. So those are the varieties of different endovascular procedures that get done. Once again, I mean, the nice thing about the endovascular procedures is it allows surgery to be safer. A lot of times it obviates the need for open surgery. They're called minimally invasive. They're just as dangerous, just as risky as the open procedures. The nice thing is patient recovery is a lot faster. Patients very often will go home faster. In terms of patient management and care, it's the same as a craniotomy patient. The neurocheck is the key, and they can be just as sick just as quickly, but maybe for some different reasons. So that runs the gamut of endovascular. Hopefully, will be our practice will be bringing some of that here.
Now, what about when you do the embolism for like a tumor to be removed? How long, like is it you bring the patient in, you do that, and then the patient stays until then you do the surgery to have the tumor removed, or do they go home and come back, weeks later?
No, we generally do it the next day. We don't have to, but in general we do. Sometimes we want to do it the next day because if you embolize a tumor up in the brain, it swells afterwards. So we want to watch them, but we don't want to do it too far ahead of time because we don't want it to really swell and make the person worse. So we'll do it, watch them in the hospital, make sure they don't get sick that night, or the tumor doesn't hemorrhage that night from cutting off the blood supply to it. I told you it necroses, and then it can bleed into itself. But generally we do it the next day. Occasionally we'll wait if we want the tumor to necrose to make it really soft so that you can and take it out more easily just by taking out dead tissue instead of relatively tissue that was alive more recently. Because just like anything dead, it tends to necrose and melt over time and get softer. In the elderly, sometimes you'll just embolize a tumor. That's symptomatic, with the hope, because they're symptomatic from it. You would like to take it out, they're too sick to take it out, but if you embolize it and it necroses and dies, it may shrink, and some of the symptoms they have may go away, so you can leave it in that way. But 99% of the time it's done and they go home, and they either go home the next day or it's resected the next day.
How often is there like a preparation for a rupture?
For an aneurysm?
Yeah, like when you're doing the wires and the catheters.
Yeah.
And what's it, like how fast do you have to, can you repair that endovascular, or do you have to open them?
It's very rare we have to open the patient up, because if it's that kind of, if you can't stop the bleeding endovascularly, they're going to die before you can get them to the OR.
Great.
It doesn't happen that often. With AVMs, it's less of a problem because we're generally in a vessel we're going to get rid of anyway. So it's just that it may have ruptured during the embolization, or it may have ruptured right before I was going to embolize. So you just go ahead and embolize it and get rid of the vessel and stop the bleeding very quickly. For aneurysms, it's a little more of a problem because until you fill the aneurysm with all of the coils, it can keep bleeding. We do those patients asleep so that if it ruptures, they don't move, they're under anesthesia already. We're monitoring their brainwave activity. As long as their brainwave activity stays the same, we keep coiling it. Usually we keep putting coils in, we'll seal it up pretty quickly. And then we may put a drain in, an external ventricular drain in them if they don't have one. In patients that we're coiling them and their brainwave activity gets really bad before we're able to stop the bleeding, we'll put the ventriculostomy in right there, and then we'll keep coiling it. The incidence for an unruptured aneurysm, for any type of major complication, so somebody basically waking up worse than they went to sleep, this is for an elective unruptured aneurysm, is 3%.
Okay.
For ruptured aneurysms, it's different, but it's hard to tell exactly what it is because they also have the comorbidities of the ruptured aneurysm itself. It's not that common to rupture an unruptured aneurysm. It's more common to rupture an already ruptured aneurysm because it's already weak. And the smaller the aneurysm, the greater the likelihood you're going to rupture it, because you only have a small area that you can get the catheter into and the coils into, versus a big aneurysm where you have a lot of leeway on getting into it, putting the catheter safely into the aneurysm.
With those coils, do they have to take, like with a stent with the heart, do they have to take any medication to keep that open or anything?
Yeah, we put them on, if we're using a stent, we generally, all the patients are, for endovascular procedures, almost all of them, they're heparinized during the procedure. If we're putting stents in, we will very often give them, if it's safe to, give them integralin, which is a very potent platelet inhibitor. We'll give them integralin after the stent is in or right before the stent goes in, depending on what things look like. The integralin, if we give them, we'll keep it going for 12 to 24 hours after the procedure. We'll load them with Plavix, either ahead of the procedure if we know we're going to use a stent, or we'll give it through an all-gastric tube at the end of the procedure. It takes the Plavix about 4 hours to become active. That's the period of time while the integralin is working. The integralin wears off in 4 hours, and by that time the Plavix kicks in. In elective patients, we swab all of their mucosa preoperatively and send it off for genetic testing to see whether they're Plavix responders or not. We do that in the office. We can also do that in the hospital if they're an inpatient, but we can't do it ahead of time, obviously, so we know we're going to use it. For aneurysms or any other, if we're coiling an aneurysm and we're not putting a stent in with it, just coiling it, generally they're heparinized during the procedure. We'll leave them on very low dose heparin after the procedure, like 500 units an hour. We don't check a PT, PTT, and stop in the morning.
You don't check.
No, because they're only at 500 an hour. They're not going to be therapeutic, but it probably gives them a little bit of protection. Oh, and everybody goes on aspirin if it's safe after the procedure. And they stay on aspirin forever. Most of our patients are the age they should be on aspirin anyways. They just take a baby aspirin a day. And that's one more thing. Plavix for a stent, 6 months. And then if there's no other indication for keeping it on, we stop it after 6 months and just keep them on aspirin.
Of those procedures you went over, how many of those go home same day? Like that list of interventional procedures? Which ones go home same day?
Balloon test occlusions do, right, Ken? Sclerotherapies do. That about it?
That's all.
Yeah, everybody else stays
Plain
on.
diagnostic angio, they go home the same day, but the test solutions go home.
If we were to, there are some things we're just not going to be doing a lot of here. We're not going to be doing a lot of balloon test occlusions because we're not going to see that kind of pathology up here. For all intents and purposes, anything we do endovascularly here is going to stay overnight, at least. Angiograms, diagnostic angiograms go home if everything's fine after 3 hours.
Those are the ones that are done like after you're like 6 months or 2 years?
After coiling, if somebody maybe is coming for a diagnostic angiogram for some other reason, just like they come in for a cath in their heart, they go home the same day. Any other questions?
I think the medications, Xarelto, we use it sometimes on cath patients. Someone that would have an aneurysm repair with the coil, like if someone that has a bleed isn't allowed to take that medication, would they be the similar situation?
I don't know
They've ever had a
what
bleed.
does that medication do?
It's similar to Plavix, but if you've ever had a brain bleed, you're not supposed to take it.
No, we have, I mean, I would say, well, we use stents in about 25% of our aneurysm patients, and probably in about 15% of our ruptured aneurysm patients, and they all end up on Plavix. Unless there's some contraindication, but not, the contraindication is not their head, it's their GI bleeder or something else. Once it's fixed, it's fixed. The chance of rebleeding from a treated aneurysm is 1% or less.